Good morning all. We can see the other menstrual abnormalities. Part 2. Dysmenorrhea. It is also known as painful periods of menstrual cramps. It is a pain during the menstruation. Dysmenorrhea is a term describing painful menstruation that typically involves cramps caused by uterine contractions. Dysmenorrhea is divided into two categories, primary dysmenorrhea and secondary dysmenorrhea. Primary dysmenorrhea is painful menstruation with no identifiable pelvic pathology. Highest level is in the first 2 days of menses. Primary dysmenorrhea causes increased prostaglandin production by endometrium in an ovulatory cycle, which causes contraction of the uterus. Secondary dysmenorrhea is a painful menstruation due to pelvic or uterine pathology. Secondary dysmenorrhea causes are endometriosis, adenomyosis, pelvic infections, uterine fibroids, intrauterine devices, congenital uterine or vaginal wall abnormality. Pain in the lower abdomen is common. Pain may radiate to lower back and to the thighs. Pain may be sharp, pelvic cramps or deep and dull ache. Primary dysmenorrhea starts from 12 to 24 hours before the onset of menses. Abdominal pain often accompanied by nausea, diarrhea, fatigue, lightheadedness or headache or dizziness. Secondary dysmenorrhea usually occurs after the woman have experienced a problem free periods for some time. Pain may be unilateral, constant, continuous, longer than primary dysmenorrhea. Cramping pain with menstruation and physical examination is completely normal. If the signs and symptoms are the findings, then further diagnostic evaluation are done, like laboratory tests for CBC to rule out any infections, urine analysis to rule out any UTI, cervical culture to exclude sexually transmitted infections, ESR to detect any inflammatory process. Pain relief by non-steroid anti-inflammatory drugs, low dose of oral contraceptive pills, heat applications. Heat is applied to the lower abdomen or back may reduce dysmenorrhea. Lifestyle changes like daily exercise, weight care, weight loss, smoking cessation, relaxation techniques, sleep and rest for adequate time, avoid unnecessary workload. Management of secondary dysmenorrhea is directed to the diagnosis and treatment of underlying causes like endometriosis or pelvic inflammatory diseases. Premenstrual syndrome. It refers to physical and emotional symptoms that occur in 1 to 2 weeks before the woman's menstrual period. Common symptoms include acne, tender breast, bloating, feeling tired, irritability, and mood changes. Symptoms of premenstrual syndrome include mood swings, depression or feelings of hopelessness, intense anger and conflict with other people, tension, anxiety and irritability, decreased interest in usual activities, difficulty in concentrating, fatigue, change in appetite. Causes. Exactly what causes premenstrual syndrome is still unknown, but several factors may contribute to the condition. First one, cyclic changes in hormones. Signs and symptoms of premenstrual syndrome change with hormonal fluctuations and disappear with pregnancy and menopause. Chemical changes in the brain. Fluctuations of serotonin, a brain chemical that is a neurotransmitter that's thought to play a crucial role in mood states, could trigger the PMS symptoms. Insufficient amount of serotonin may contribute to premenstrual depressions as well as to fatigue, mood, food cravings and sleep problems, depression. Some women with severe premenstrual syndrome have undiagnosed depression, though depression alone does not cause all of these symptoms. The management include many treatments have been tried in PMS. Reducing the salt, caffeine and stress along with increasing exercise is typically all that recommended in those with mild symptoms. Calcium and vitamin D supplementation may be useful in some. Anti-inflammatory drugs may help with physical symptoms. In those with more significant symptoms, birth control pills may be useful. Diuretics have been used to handle water retention. Spironolactone has been shown in some studies to be useful. Metrorrhagia or hypermenorrhea. It is a cyclic bleeding at normal intervals. Bleeding is either excessive amount, that means more than 80 ml, or duration, or both. Causes are pelvic pathologies like fibroid uterus, adenomyosis, pelvic endometriosis, IUCD, chronic tubo ovarian mass, tubercular endometritis, retroverted uterus, and granulocyte cell tumor of the ovary. Systemic causes like liver dysfunction, congestive cardiac failure, severe hypertension, endocrinal like hypothyroidism, hyperthyroidism, blood disturbances like ITP, leukemia and non-Willebrand disease, functional like DUB, fibroid adenomyosis, chronic tubo-ovarian mass. The diagnosis, its treatment, definitive treatment is appropriate to the cause of menorrhagia. Epimenorrhea or polymenorrhea, cyclic bleeding where the cycle is reduced to an arbitrary limit of 21 days or less remains constant at that frequency. If the cycle is associated with excessive and or prolonged, the causes include dysfunctional predominantly during adolescence, preceding menopause and following delivery and abortion. Hyperstimulation of the ovary by pituitary hormones may be the responsible factor. Ovarian hyperemia as in PID or ovarian endometriosis. Treatment: persistent dysfunctional type is to be treated by hormone as outlined in dysfunctional uterine bleeding. Metrorrhagia, it is defined as irregular acyclic bleeding from the uterus. Amount of bleeding is variable. Metrorrhagia is the term applied when the bleeding is so irregular and excessive that the periods cannot be identified at all. Metrorrhagia may be a sign of an underlying disorder such as hormone imbalance, endometriosis, uterine fibroids, or less commonly cancer of the uterus. Causes of acyclic bleeding. First one is DUP, usually during adolescence, following childbirth and abortion, preceding menopause, submucous fibroid, uterine polyp, carcinoma of the cervix, and endometrial carcinoma. The causes of intramenstrual bleeding include urethral ovular bleeding, breakthrough bleeding in pill use, and IUCD in utero. Treatment include it is directed to the underlying pathology. Malignancy is to be excluded prior to any definitive treatment. Thank you for listening. If you have any comments, please let